Sajid, are you there? Yes, sir. Good evening, sir. Good evening, sir.
Sir, good evening. Good evening. Yeah, I'm here, sir. Sir, actually, Vaishak sir join ചെയ്യാമെന്ന് പറഞ്ഞിട്ടുണ്ട് വിത്തിൻ 5 minutes സ്പീക്കേഴ്സ്. എന്നെ മരുൺ സാറിന് ഒരു മരണത്തിന്റെ കേസ് ഉണ്ട്. ആള് ഡ്രൈവിംഗിലാണ്, ജോയിൻ ചെയ്യാമെന്ന് പറഞ്ഞിട്ട് ഇൻ ബിറ്റ്വീൻ.
Okay.
So,
Okay.
I think we will start, sir, within 5 minutes.
Sir, good evening, doctors. Doctors, can you? It would be great, like everybody switch on the cameras, means you can interact it with better way.
സാർ നമുക്ക് സ്റ്റാർട്ട് ചെയ്താൽ വിത്തിൻ 5 minutes ബാക്കി എല്ലാവരും ജോയിൻ ചെയ്യാൻ പറഞ്ഞിട്ടുണ്ട്. ഹാസൻ സാർ കുറച്ച് നേരം വെയിറ്റ് ചെയ്യുന്നു, സോ വി ക്യാൻ സ്റ്റാർട്ട് സർ.
Fine. No issue.
Okay. So, thanks a lot, doctors. Thanks a lot for your valuable time. I know today's busy schedule and your office schedule, so thanks a lot for your valuable time, and thanks a lot for your valuable participation in our expert summit. And I welcome all the delegates and the respected speaker to our program expert summit 2022. So today's discussion is regarding MRIs, and fortunately we are get the seniors and juniors, the mixed group with us to discuss the things. So I hand over the session to Sandeep sir. Sir, up to you, sir. We can start now, sir.
Yeah. So good evening to one and all. Basically, I am very thankful to Cipla for giving me this opportunity to be a moderator for this session. So I am working as cardiologist in Thangam Hospital in Palakkad. So I think we will slowly start the session. I'll just share my screen. So I think the slides are visible to all, no?
Yes, sir, it's visible.
Okay. So we are today going to discuss some small points regarding the melanocorticoid receptor antagonist. So which is one of the major drug which is used for any patients with heart failure. So the objectives for today is to study about the MRIs and utilization heart failure management, and hyperkalemia is really a concern in physicians' practice, and to create a small awareness on the melanocorticoid receptor antagonist. So a small introductory 1 or 2 slides, that is the global prevalence for heart failure is around 26 million people worldwide, and among the adult population, 1 to 2% of the patients have heart failure in developed countries. And usually the heart failure prevalence increases with age and rising to around 10% among people more than 70 years of age. If you see the epidemiology in India, it is the prevalence is around 1% of total population, and the annual incidence is around 0.5 to 1.8 million new cases, and mortality comes to around 0.1 to 0.16 million individuals per year. So we know that basically everybody knows to treat the heart failure, and we are only going to brush some things about the mineralocorticoid receptor antagonist today. The basic treatment for heart failure always remains the diuretics for the achieving euvolemia, and beta blockers, as you all know, is one of the major drugs which reduces mortality and morbidity in heart failure. The ACE, ARB, which are the one of the cornerstones, which also decreases the mortality in heart failure. And the other drug is the mineralocorticoid receptor antagonist, which also decreases the mortality in heart failure. And the newer groups of ARNI, the ARNI group of drugs, which are also there in heart failure now, they are also found to have reduced mortality benefit, decreased mortality benefit in heart failure. And especially if consider diabetes with heart failure, with the dapagliflozin and empagliflozin group of drugs, they also have shown to have mortality benefit in heart failure. The rest of the drugs doesn't have any mortality benefit. Usually the beta blockers, ACE inhibitors, ARBs, and you have your mineralocorticoid receptor antagonist and the ARNI group of drugs. These are the major drugs which have shown benefit in heart failure, and also dapagliflozin in diabetes failure. So I think we will go to the session. Actually, Dr. Mohammed Hussain wanted to go a little bit early, so I'll start directly with question number 5. So when do you consider starting mineralocorticoid receptor in patients with in heart failure with ACE inhibitors, ARB, and beta blockers? So as you all know, the first step is to add a diuretic, second beta blockers, AC and ARB, and then slowly start on the MRAs also. So when do you want to consider MRA in patients with AC, ARB, and beta blockers? Dr. Mohammed Hassan is there? Yeah.
Hassan sir, it's audible? Sir, I think he's some problem or something. So,
okay. I can see Kunjuri sir here.
Yes, definitely, sir.
Yes. Sir, so we will go with the diagnostic and prognostic tools used for heart failure patients. So, Sujit sir, the diagnostic and prognostic tools used for heart failure. What are the usually your ways of diagnosing heart failure, and what are the prognostic things which you look upon in heart failure? Yes, sir.
Okay. In the diagnostic tool, usually we have to make a clinical diagnosis, then we have to do some investigations. Clinically, there are some symptoms like dyspnea, pedal edema. Sometimes patient feels very tired, fatigue, and these are the clinical features or symptoms as such. When we examine, we may get basal crepitation, elevated JVP, the breathing difficulty. So we get a clinical idea about the possibility of a heart failure. Now we have to do some diagnostic investigations to find out whether this is true or what are the causes of, what may be the cause behind this. For this, we can do an ECG. This will give us an idea about whether there is an acute ischemic event or any arrhythmias are there. We can take a chest X-ray. From that, if there is a cardiomegaly or if there is pleural effusion or there is the opacities in the lung tube, paracardiac lung tube, and such. From this, we get an idea about the presence of heart failure. After that, we can go for hematological investigations, mainly hemoglobin, if low hemoglobin anemia, then about the renal function, creatinine clearance, raised creatinine, or if there is a hypoalbuminemia, we have to check the albumin level. Based on this, we get some idea about the presence of cardiac failure. Then we can go for echo test, mainly for calculating the ejection fraction. Based on the ejection fraction, we can divide the group of heart failure group into three mainly, with heart failure with preserved ejection fraction and reduced ejection fraction, and in between median range of ejection fraction. So based on then we have to make a NYHA classification based on the clinical symptoms. The NYHA class 3 and 4 are mainly serious type of complicated type of heart failure. Then after echo, we decide the ejection fraction and the cardiac volumes. Okay. Then after that, we can go for TMT if possible, or a 3-minute or 6-minute walking test. Then we can proceed to cardiac catheterization, angiogram and cardiac catheterization. From all these, we can make a diagnosis as well as the cause of heart failure. Then the remaining blood test is about the biomarkers. There are many different types of biomarkers. We can have tropi, CPKMB, and myoglobin. Different types of biomarkers are used. But nowadays, the most important and commonly used is BNP and N-terminal pro-BNP. If the BNP level is more than 100 picogram per ml, it is a clear evidence of decompensated heart failure. So this is about a few words about the diagnostic tools in heart failure. Then we can go for the prognosis. In the prognosis tools of heart failure, there are also clinical and investigational parameters. In the clinical parameters, mainly it is the which NYHA class they belong to. If it is class 3 and 4, the prognosis is very bad. If there is a tachycardia more than 110 per minute, if there is a hypoxia below 90, SpO2 below 90, and if the creatinine clearance is less than 40 ml per minute, and about the cardiac biomarkers, like if the BNP level is more than 100, more than 2000, there is a very serious condition. So based on such investigations, we get a prognostic evidence, a prognostic idea about how the patient may progress, if the condition may become worse. The most important 4 criteria are the NYHA class, then the BNP level, then the creatinine clearance if it is less than 40 ml per minute. These are the most important prognostic criteria for the 1-year survival. How we can decide the 1-year survival? If these three, and age above 70. If these 4 are present, then they are unlikely to survive more than 1 year. If it is, if the condition is like this. So these are the prognostic markers. If pro-BNP, N-terminal pro-BNP more than 5,000 and the BNP level more than 2,000, then it is very unlikely that they survive beyond 1 year. Then there are some novel biomarkers. Some of them are only in the research level. Some are gradually being incorporated into our guidelines. That the novel biomarkers, in that category comes the soluble ST2 and galactin-3 and some of the endothelin-1, and some of these are gradually being incorporated into the guidelines. These are the novel biomarkers. So such biomarkers and the echo, all these give us an idea about the prognosis of the heart failure.
Yes, sir. Sir has already extensively talked about the diagnostic and the prognostic tools. As rightly said, basically the clinical examination should be above everything. And as sir has already told, the raised AVP, the presence of rails, the presence of LVS3, all these are very important when patient examine the patient clinical status of the patient. And once we find that the clinical subset is fitting into heart failure, then definitely the blood investigations, as sir has already rightly mentioned, the basic blood routine examination, the ECG, the echocardiogram, chest X-ray, and especially the biomarkers. Biomarkers can be used as both for diagnosis as well as for prognosis. No, sir, as you told already, it can be used as for diagnosis and as well as for the prognosis also. So once the diagnosis is made, the prognostic tools, as Sir has already mentioned, NIHA class is one of the major determinant of the prognosis. And as the NIHA class goes to 4, the survival rates actually decrease. And if you consider some other factors, the other factors are like the female sex. So presence of females and males. Females actually do better when compared to males. And younger age, there is a better prognosis when compared to older age. And this has been evaluated in the fetal HF model, where you can have the fetal HF model can be seen that there were many free prognostic variables can be seen from the fetal HF model. And you can calculate the mortality rate when you put the NIHA class and other things into it. And another one of the uncommon things which are seen is anemia, presence of anemia. So anemia and heart failure is, you have to be very careful because anemia actually increases the mortality in heart failure, especially iron deficiency anemia. So the AHA recommends the treatment of iron with IV iron if the patient is having clinical anemia and if the patient's serum ferritin is less than 100 nanogram per ml and with the transferrin saturation is also low. So in such patients, IV preparation of iron can be given for the patient. So anemia is one of the major factors, and as I told already, the CKD or the creatinine clearance, as the creatinine level rises and the mortality rates also increases. As for there is a other registry for that. The other registry shows that as the creatinine rises or as the EGFR, when you calculate, that decreases, patients have a poor prognosis when compared to patients having a baseline good creatinine. One is because the creatinine itself can impair your treatment strategy. So once the creatinine rises, once you give more diuretics, the patient can develop more of a prerenal type of azotemia, which can, in turn, you have to decrease the diuretics, patient will again go for heart failure. You cannot give the drugs like spironolactone or AC inhibitor ARB when the creatinine starts to raise. And even hyperkalemia can also be present, which also inhibits all these, giving these drugs. And even digoxin can precipitate arrhythmias once when you give it when there is a rise in potassium levels. So as Sir already told, these are the variables, and as pro-BNP and the other clinical variables are the major ones which are important for the prognosis. And also the novel biomarkers which are not yet come to the AHA guidelines, which slowly will seep into the guidelines in the pipeline. As of now, the used one is the pro-BNP and the BNP levels. As I already told, BNP levels more than very high levels shows grave prognosis in heart failure. And apart from this, also troponin can be elevated mildly in any heart failure. So, like many reference can be seen, it's slight troponin elevation. Slight troponin elevation is very common in heart failure because of the stretch of the muscle. There can be slight troponin elevation, and the troponin elevation also is a prognostic marker. So, patients who have got a very high troponin elevation, not suggestive of a myocardial infarction, but still have troponin elevation, those patients have lesser survival rates when patients having normal troponin, when compared to patients having normal troponin. So these are the prognostic tools and the diagnostic tools in heart failure. So if you ask me what is the one diagnostic tool which can be, which should be used, or which is the most important one, that is echocardiogram. So echocardiogram will definitely show how the patients, it is both useful for diagnosis as well as prognosis. So once you find out the ejection fraction, it is one of the major breakthrough. Like you are diagnosing a heart failure, not diagnosing heart. It's like a traffic light. So most important one among all these is echocardiogram. Yes, sir. So we go on to the next question. I think Hassan sir is waiting, I think. So Hassan sir, you are there, sir? Vasan sir, am I audible to you, sir? I think we'll go with the next question. It is question number 3. Dr. Raju is, I think, sitting.
Yeah, I'm there.
Yes, sir. Okay. So, are these parameters like potassium levels, creatine, EGFR tested before and after initiating MRS? And how long in practice do you test these parameters for potassium, creatine, and EGFR? How do you find it as a useful thing, and how often you do it? Yes, sir. Over to you.
Basically, we on starting treatment, we usually evaluate with serum creatine and serum potassium to check the status of the patient before starting a MRI. So, as per the guidelines, if the serum potassium is less than 5, we can initiate MRI, and if the creatine is again less than 2.5 in males and 2.0 in females, we can initiate on MRS. That's how we, during initiation, we check both parameters. And further, on follow-up, there is a recommendation both by ACC and ESC. Like in ACC, it has been told that we follow up serum creatine and potassium after the initiation of the treatment within 72 hours or 1 week. Usually in the practice also, we follow the same thing. Then every 4 weeks for the first 3 months, we follow the parameters. Following which, after the first 3 months, then every 3 months, we'll have to follow up with serum potassium and serum creatine. And if there is any rise in serum potassium, like if it goes above 5.5 to 5.9, we'll have to taper the doses of spironolactone or epilon, whichever MRI we are using. Either if it's already in the lower dose, we are starting the treatment, we'll have to make the treatment on alternate day basis based on the potassium levels. Or if the serum creatine goes up, we'll have to hold the mineralocorticoid receptor antagonist. Like if the serum potassium is more than 6, we'll have to stop the medicine, and we'll have to follow up with every 72 hours. Once the potassium stabilizes, we can reinitiate the treatment under close monitoring.
Yes. So aptly told, the caution should be exercise when MRIs are used when serum potassium is more than 5, and severe impairment of renal function, that is EGFR less than 30, or creatine more than 2.5 in men or more than 2 in women. We should be not be using. Actually, it is class 3 recommendation for usage of spironolactone or eplerenone for that purpose. And it has to be checked, as rightly told, on the first before initiation, and after 3 days, then 1 week, then up to 6 months you have to check it monthly. And if the potassium levels are rising, you have to decrease the dose or make it alternate day dosage, and then slowly continue or withdraw, as Sir has already told. Correct. So we will go to the next question, question number 4. Dr. Vaishak, in what percentage of patients you use the mineralocorticoid receptor antagonist for heart failure management? How is your strategy for that? Yeah,
I'm audible, right?
Yeah, you're audible.
Yeah. So I think that has been already been discussed by all the previous doctors. Generally, we do look at a lot of parameters before starting for heart failure, and basically the first thing, as we said, based on the creatine levels and the existing sodium and potassium status. So many patients who come with heart failure generally do tend to have creatine levels on the slightly higher side, be it males or females. And so we generally, I'm a bit cautious, and I would say about 50 to 60% patients, yeah, we do initiate, but again, based on the future reference, as we say, the potassium levels, based on tendency for the heart rate variations, and again, based on baseline creatinine levels, we might either tend to reduce it or increase the dose. Again, another consideration here might be is sodium levels, which tend to rapidly fluctuate, as important as potassium levels. So especially in a patient's older age, with mostly persistent with heart failure, I see they go for tendency for hyponatremia very easily. And so I would say 50 to 60% patients in clinical practice is what would be basic this thing. And I think all the other points have been already been discussed regarding the follow-up and when to taper and stop. So yeah, so I think that would be the ideal percentage in this case. Yeah.
Yes, yes. At least it's so like 50%, more than 50%. Yeah.
Yeah.
So once your heart failure ejection fraction is 35%, less than 35%, symptomatic heart failure less than 35%, patient on ACE inhibitor ARB, you should start on mineralocorticoid receptor antagonist. So 2 to 4, in class 2 to 4 NIHA, with ejection fraction of less than 35% or even less than 40% for mortality benefit, you should start on the mineralocorticoid receptor antagonist. So the class 1 recommendations for reduced ejection fraction and for decreasing the hospitalization and death, and it is class 2B4, mildly reduced ejection fraction, that is ejection fraction of 40 to 49%. That is the mildly reduced ejection fraction as per the ESC guideline, and reduced ejection fraction less than 40%. In such cases, the class of recommendation goes to class 1, and class 2B in case of heart failure, mildly reduced ejection fraction. So NIHA class 2-4, the ejection fraction less than 35 is class 1A recommendation. And to reduce the mortality and morbidity in acute myocardial infarction also with ejection fraction less than 40, who develop symptoms of heart failure or who have diabetes unless contraindicated, is class 1B. And class 3, that is not recommended when potassium is more than 5, that already Dr. Regis already told about it. When the potassium is more than 5 or creatinine is more than 2.5 in men or more than 2 in women. So any symptomatic heart failure, NIHA class 2-4, with ejection fraction of 35 to 40%, they should be initiated with the MRA. Correct. Thank you. Thank you. Yeah. We'll go to the next question, I think. Dr. Dipin is there, I think. Yes.
Yes.
Dr. Dipin, good evening. Yeah.
Good evening. Good evening, sir.
Okay. So when do you prefer using eplerenone and spironolactone? Is there any specific profile for you, or like how is the how do you which patients you prefer eplerenone and which patients spironolactone? Any specific patient profile is there?
Yes. Yes.
Over to you, sir.
Thank you, sir, for giving me this opportunity. This is an important scenario because our preference will vary from person to person. So first and foremost thing is about the cost. That why we select spironolactone versus eplerenone, because one tablet of 25 mg spironolactone costs around 2 rupees, while eplerenone costs around 20 rupees. That will be the first criteria. And if we start eplerenone, the patient should be able to buy that. So first thing, we the patient profile we have to assess. His economic status we should assess. So next thing is about the receptor specificity. Spironolactone is not at all specific for mineralocorticoid receptor. So it acts on other receptors like androgen and progesterone receptors, and it causes breast pain, gynecomastia, menstrual irregularities, and all. So in these patients having gynecomastia or menstrual irregularities, so the spironolactone is not started, and instead eplerenone is preferred over spironolactone. About another patient profile is heart failure with diabetes. That is an important scenario because usually the MRAs will improve endothelial dysfunction in patients with heart failure. But in diabetic patients, one thing is spironolactone worsen SbA1c, that is worsens diabetic control, and in effect leading to worsening of the endothelial dysfunction. So in patients with diabetes, the drug of choice is, among MRAs, it would be eplerenone. And about those patients with metabolic syndrome and morbid obesity, there will be an increased adiponectin level and increased steroid secretions with spironolactone. So in those patients, set of patients, spironolactone is less preferred, and if at all possible, eplerenone is preferred. And in those patients who have a risk of hyperkalemia and acute kidney injury, they've already this thing discussed. And the main set of patients would be those patients on highest dose of ARBs, and also those with the borderline creatinine values. There is a high risk of hyperkalemia. So in those set of patients, eplerenone is preferred over spironolactone. And another important scenario, that is about patient compliance. Some set of patients, they will be started on MRIs, and there is we could easily understand that they may not come for regular follow-up. So there is chance for hyperkalemia and other complications with spironolactone. So if we think that this patient, there is a chance for non-regular follow-up, so in those set of patients, the eplerenone would be preferred over spironolactone. So these are the considerations I will look after in my day-to-day practice.
Excellent, sir. Excellent. Yes. Like the most important thing is the price factor, as sir has already told. So like you have the price of the eplerenone is actually very high when compared to spironolactone. Spironolactone is very cheaper. The spironolactone, as you know, is the first derivative, and the second generation is the eplerenone. So as the specificity is more for the eplerenone, and the half-life is shorter for eplerenone, whereas you have longer half-life for spironolactone. And another thing is there is no active metabolite for the eplerenone, whereas spironolactone, you have an active metabolite, candrenone, and there is no gynecomastia, as Dr. Vinay has already told, because the 17-alpha thiacetyl moiety has been replaced here in the eplerenone. So you have lesser gynecomastia and other anti-androgenic effects are very less with eplerenone when compared to spironolactone. And obese patients definitely, and based on creatine levels, when patient is high, definitely eplerenone. But if you compare the spironolactone versus eplerenone and LV function in patients with heart failure, the small study which was done around 250 patients, it was found that the LV function was significantly improved in the eplerenone arm when compared to the spironolactone arm. So you have one of those studies which shows that eplerenone had a better outcome when compared to the spironolactone. But both are well-proven molecules, and price should be, I think, one of the major concern in your everyday day-to-day practice. And if you take the trials, both the trials for the spironolactone, which was done for class 3 and class 4 heart failure with ejection fraction less than 35%, showed 30% decrease in the mortality. And you have the emphasis and the EPHYSIS trial for the spironolactone. The EMPhASIS trial, which was used for class 2 and 3, NEHA, and with ejection fraction of less than 30%, also showed 27% decrease in the mortality. And the EPHYSIS trial was done in case of myocardial infarction with ejection fraction less than 40%. There was a 15% decrease in the mortality in the subset. So when you compare both of them, eplerenone has a slightly more advantage when compared to spironolactone. The only thing, the major thing which hampers is gynecomastia. 10% of the patients can have gynecomastia with spironolactone because of the 17-alpha thiacetyl moiety that can impede the androgenic effects. So major concern should be price and gynecomastia. So we will go on to the next question, I think Farish sir is here. So, Dr. Farish sir, can you hear? Yeah. Yes, sir. So what percentage of heart failure patients on MRI develop hyperkalemia, and do they require discontinuation of treatment? What is your opinion about that? We all know that hyperkalemia is very common with mineralocorticoid receptor antagonists. And how do you go about it? I think a small part was discussed previously, but still, how do you What is your personal opinion, sir? That? Yeah.
I do get a couple of patients because almost all the patients have CKD. It may not be just about the epinol or spironolactone, but it is multi-causative problems issues. It may be most of the patients, almost more than 50% may have a CKD while coming to our hospital, especially when we are having a referral hospital. So I cannot fully comment about the thing about the epinol or spironolactone.
Okay. And do you require discontinuation of treatment, sir? And what do you personally do, sir? You discontinue the treatment or like? Yes, sir.
Yeah, we consult with our cardiology and we tell them to either switch to something or to reduce the dose, or we do an alternative options we can be searched out.
Okay. So if you see the hyperkalemia in mineralocorticoids of antagonist, usually even though it is reported as very high, the percentage of hyperkalemia prevalence is only 9.3%, out of which the 54% was truly related to mineralocorticoid receptor antagonist. So this is from the meta-analysis from various trials in the and the trials, the first trial. So the prevalence of hyperkalemia is around 9.3 to 10%, and out of which the 54%, that is approximately 4% of patients, were truly the hyperkalemia was truly related to mineralocorticoid receptor antagonist. So when you find that the potassium levels are rising, so if it is more than 5.5 to 5.9, as already it was discussed, I think. So if the dose is 50 milligram, you slowly decrease it to 25 milligram. If it is 25, decrease to 25 milligram alternate day. If it is 25 milligram, even you can go with half of the tablet, or then stop it and then reassess the potassium level after 1 week. If it is more than 6, then you better to stop the MRI and reassess the potassium levels after 1 week. And if it is less than 6%, initiate the potassium binders and then slowly reintroduce the MRI. And if the eGFR is less than 30 ml, or if the creatinine is rising more than 2.5, better to not to give eplerenone or the spironolactone. So same thing for eplerenone, 50 milligram decrease to 25 milligram. If it is 25, then make it to half, and then or make it to alternate day and reassess. And then after 1 week, if still it is going on like that, then take some other therapies. Or if the potassium levels are coming down, then slowly initiate and try with the smaller dose, and then slowly uptitrate it. Yes, sir. I think we are left with 1 or 2 questions, I think. Dr. Mohammed Hassan sir has joined. Mohammed Hassan sir.
Sir, actually, he has some emergency. He's messaged me. So he's extremely sorry for the inconvenience, and he's messaged.
Okay. So we will discuss that question, I think, so when do you consider starting the MRI in patients with heart failure along with ACE, ARB, and beta blockers? So this was the question, I think, Mohammed Hassan sir. So when you in any case of heart failure, whether it is AC, whether it is, I think I already told this thing. So class 3 and class 4 patients, class 2 to 4, the ejection fraction less than 35. It is a class 1A recommendation. And to reduce the morbidity and mortality in acute myocardial infarction, the ejection fraction less than 40, who develop symptoms of heart failure or who have history of diabetes mellitus unless contraindicates class 1B. And it is contraindicated when potassium is more than 5 and creatinine is more than 2.5 in men and more than 2 in women. Yes. Arun sir has joined.
Joined, sir, but he's left. Actually, he has some death case and he is going for that funeral. On the way he's joined, and 5-10 minutes he's wait.
Okay. So what percentage of heart failure patients is approached in NIHA class 2, 3, and 4? How many heart failure patients goes undiagnosed in India at an early stage, and why? So we all know that in India the diagnosis is very much late. So main thing is that because of the financial constraints, patient usually take the label the heart failure as asthma, and they will take their own Deriphyllin or Aspalin, their own treatment, and then only come to the hospital. So usually, whichever patient comes is usually class 3 or class 4. I have never seen class 2 and all coming to hospital. Usually it is class 3. Most commonly it is heart failure. Patient presents with overt heart failure, decompensated acute decompensated heart failure in pulmonary edema. That is class 4. And why it goes undiagnosed is we all should initiate the common practice to do a cardiac evaluation for diabetic patients, especially long-standing diabetes and hypertension, because IST is one of the major killer in any diabetes and hypertension. So should be routinely practiced to take an ECG, echo, and even a TMT for. I think Gunjari sir has already told that for patients with long-standing diabetes and hypertension. So that is the thing which you can do. So why it is undiagnosed is because of the lack of knowledge among people. The people themselves, they don't go to the doctor, or they treat the heart failure as they think that they have only asthma and no heart failure, or maybe seasonal, or because of rain. Many reasons are there. So all these things, and they become they are underdiagnosed. That is the main reason for that. I think we have covered all the questions for this one. There are some open questions. So how early are the MRIs initiated for management of heart failure in patients? So anybody wants to answer this? Like how early are the MRIs initiated? Yes, Dr. Divin sir. Yeah.
Yes. Usually, if the patient presented with acute decompensated heart failure, we should manage the patient to attain euvolemia, and slowly ARBs will be introduced. ARB or ACE inhibitors will be introduced, followed by beta blockers. And by around 2 weeks, 10 days to 14 days, the MRIs, if there are no contraindications, they should be introduced. Because otherwise, there can be a chance for hyperkalemia and all.
Yes. So as rightly told, when the patient comes with heart failure, the first thing is to make them euvolemic. So once the euvolemia is achieved and once the heart rate is in your target limit, then start on beta blockers, AC and ARB. Slowly uptitrate the beta blocker. So usually you can take 1 week for slowly uptitrate. And AC ARB can take 48 hours. Every 48 hours, slowly you can increase the dose. So better to start early, as Sir Dipin already told. So you should MRI should be started as early as possible on top of treatment, that is AC and ARB and beta blockers, preferably at discharge after episode of decompensated heart failure. So what happens if you delay is there is a thing called as aldosterone escape. So once once you administer AC levels, the aldosterone level usually comes down. Now, once you see the axis is there. So once the AC or ARB is introduced, definitely the angiotensin II levels are decreased, and hence the aldosterone level should come down. But what happens is that there will be aldosterone escape phenomenon. That is, aldosterone will be secreted from some other part. So even if you give AC with ARB, usually you should not give AC plus ARB. Usually it is not recommended because of increased chance for hyperkalemia. So aldosterone levels becomes uncontrolled, and aldosterone escape will promote again release of angiotensin II via positive feedback loop, and it again stimulates the AC in vasculature. So better is to avoid this. Better is to start the eplerenone or spironolactone early, that is at discharge. So the timing of the start of the MRI was done in the thesis trial. So it was found out that if it is started less than 7 days or after 7 days, so if it was started less than 7 days, there was 31% reduction in the all-cause mortality in patients with heart failure post myocardial infarction by eplerenone versus placebo when initiated before 7 days. And there was 34% reduction in sudden death in patients with heart failure post myocardial infarction by eplerenone versus placebo when the initiation was done within 7 days. That is, so better to take it as like discharge time, maybe discharge or 1 or 2 days after discharge. First start achieve euvolemia, as Dr. Divin told already. Then start on beta blockers. Maintain a heart rate always between around 50 to 60. That is best heart rate, 50 to 60 in heart failure. And then start on the ACE, ARB. Then if you want, you can also start on, there is no mortality benefit with digoxin. Only thing is symptoms of and admissions of heart failure will be reduced with digoxin. Just study in the DIG trial. It showed that the hospitalization rates will be decreased, but there is no mortality benefit for digoxin. So that can be given if patient has got a very severe LV dysfunction and you want to decrease the symptoms. For that, you can give digoxin. So maintain a heart rate of around, usually what I practice is around 55 to 60, maintain the heart rate with a good amount of beta blockade and ACE or ARB, and then start on the spironolactone in the first week or maybe within the first week. Monitor the potassium levels and sodium levels. One thing which I have seen in my practice is the presence of hyponatremia. It is very common with spironolactone, even though we don't have any mention on that. This I don't know what is the reason for that, but many of the patients, even at the half dose of 25 milligram aldactone, patient comes with hyponatremia. So even though this is not reported in the books or anything, but in clinical practice, I have seen that many patients who are on aldactone develops hyponatremia. So any patients managing the heart failure, the first drug should be the ACE, beta blockers, diuretics, and the melanocorticoid receptor antagonist. If the heart failure is, the patient has a clinical heart failure and ejection fraction is less than 40 or less than 35%. And any other indications apart from the heart failure where the MRA is used for any therapies? Any other indications?
We can use it in resistant hypertension.
Yes, sir. Resistant hypertension. Yes, sir.
Resistant hypertension we can use.
Yes, sir.
Also when there is spironolactone induced gynecomastia, we can substitute with eplerenone. Similarly, eplerenone can be used in cirrhosis.
Yes, sir. Yes, sir. Yes, sir. Yes. Cirrhosis and this. Yes, sir. Primary hyperaldosteronism.
Primary hyperaldosteronism.
Yes, sir. Yes, sir. Yes, sir. Resistant hypertension, if along with CCB, long-acting telmisartan or any of the sartans, plus thiazide diuretic. If patient's BP is very high, it is shown that spironolactone has got a very positive role. The Pathway 2 study was studied for that. So it shows that it is add-on drug for resistant hypertension. Also, as I told, the primary hyperaldosteronism and ascites. And also for some skin conditions like hidradenitis suppurativa, where the androgen plays a role, it can be tried, one of the tried therapy. Also for androgenic type of alopecia in females. So it is for anti-androgenic effect. Some of the books recommend usage of spironolactone. Also from systemic alopecia due to systemic cancer. In such case also can be tried. Then what scientific initiatives would you suggest to? I don't know. For increasing awareness among the consulting physicians. I think heart failure clinics are one of the very good initiatives where these people can do some free potassium testing, weight monitoring. That is very important. Weight is also one of the major thing which you can do in your bedside clinic. So if patient has come with heart failure, overt heart failure, and you want to daily echo, doing an echo is difficult. So if you daily practice the urine output and the weight chart, it can make a great difference. Like whether the patient is going in for heart failure, patient will definitely slowly gain the weight. And if patient is achieving euvolemia, slowly he will start losing the weight. So that can be used to assess the diuretic dosage on a daily basis. Daily weight chart. I think you should practice in medical colleges. The daily weight chart will be there where you can assess the right amount of diuretic with weight chart. and your skin turgor and JVP. You can decrease the dose of diuretic or increase the dose of diuretic as and when required. So for Cipla, I think heart failure clinic can be. Any other suggestions, Kunjari sir, Dr. Divi? Yes. Dr. Vaishak, yeah. Parish sir has joined, I think. Dr. Raju, any suggestions? Yes.
Such classes will help with that will help. More number of classes, more number of meetings, that will help.
Correct, sir. Correct, sir. I think Cipla fellows are receiving. Prajesh, yeah, sir is suggesting more amount of meetings for heart failure.
Definitely, sir. Definitely, it's a good suggestion from. We will took these suggestions to the HO level, sir. Definitely.
Okay. Any other suggestions, Dr. Raju, sir? Any suggestions?
No, sir. Nothing specifically.
Okay. Any things to clarify, sir? Dr. Dibin, any things to, yeah.
I think, sir.
Okay. I think we will conclude the session. Call it a day anyway. Time is also up, I think 1:30. I think everybody has to have their dinner also. So it was a very nice meeting, I think. Yeah. Kunjari sir is like my teacher. He's been practicing medicine since very long time. I think before I started, maybe 10th or 12th. So when I was in 10th or 12th, I used to see his prescriptions. I used to think that I had also to become like a physician. Like I practiced for 3-4 years, 3 years after my MD medicine. After that, then only slowly moved into subspecialty cardiology. And still I practice with Kunjari sir, one of my nearby hospitals nearby. Arun sir is also well known to me. He's also from my place. I think Dr. Raju is working in which place? Yeah.
I'm working at Pioneer.
Okay, Pioneer. Okay. And Dr. Dibin, you are working in?
ICRA Hospital, Sultan Bathery.
Oh, ICRA has started one hospital in Sultan Bathery. It is not in Calicut.
Yeah, main center is from Calicut, and it has branches in a few branches, 5 to 6 branches are there.
Okay.
It's been 4 years in Sultan Bathery, ICRA.
Okay. When we were studying MBBS in Calicut, this was like a booth bungalow, this ICRA. Nobody used to go there. In 2000, when we were studying MBBS. So it was a very big hospital, very big setup, but nobody was going there for any treatment or anything. Near to that Malapramba Junction, this ICRA hospital. But
now it's almost it's almost like
it is one of the best hospitals. Okay, yeah, I heard that it's one of the best hospitals in Calicut nowadays. Yeah, management makes all the difference. Yes. So we will call it a day, I think. Prajesh, yeah.
Yes, sir. Actually, extremely sorry because that is my part to introduce all the speakers. I actually
no issue.
And this Vaishak sir is also from Jim Care Hospital.
Okay, Vaishak, I think he's offline. That is why I didn't ask.
Yes. Vaishak sir also from Jim Care Hospital, Kannur. And I'm extremely sorry for Mohammad Hassan sir is not able to attend the meeting. So sir is also messaged me. So I'm extremely sorry on behalf of Mohammad Hassan sir. And Arun sir is also have some personal difficulty to attend the meeting. Anyway, thanks a lot, Sandeep sir and all the delegates, because your active participation make this meeting worth. Otherwise, it's a namesake meeting, and all the participants and the moderators also have fully involvement in this meeting. So I'm extremely thank you on behalf of Cipla, and I'm extremely thank you for your valuable time and such a wonderful session. And such a wonderful message also. I'm taking all the messages to the head office level. And this is a motivation from our side to conduct this type of meeting, because your active participation is motivated us to conduct some more meetings, this same like meetings. So anyway, thanks a lot and good night.
Good night. Thank you. Good night.